Hello, everybody. Welcome to today's webinar, Solventum V.A.C Peel in Place Dressing, Enhanced Outcomes and Efficiency in Acute and Community Care. My name is Chris Quinn, Strategic Account Manager at Solventum, and I'm pleased to introduce our speaker, Cindy Miller. Cindy is a registered nurse with 48 years of experience and a recognized leader in negative pressure wound therapy since the launch of V.A.C therapy in 1995. She also has supported the expansion of V.A.C therapy throughout Europe and Asia. Currently, Cindy is the Global Chief of Nursing at Solventum's Medical Solutions Division, where she provides clinical leadership across product development and commercialization. Just a little bit of housekeeping really quick. Throughout the presentation, we invite you to submit all of your questions by typing them to the question panel found by clicking the Q&A icon at the bottom of the menu. You may submit your questions at any time. We'll collect them at the end, and we're going to make sure we have enough time to walk through those at the end. And then finally, in order to receive your certificate of attendance, we request that you complete the evaluation, which will appear in your browser after the presentation ends. Please fill it out with the survey with your contact details, and your personalized certificate of attendance will be emailed to you. The link to the survey will also be available in the follow-up thank you email as well. And also, anybody in French-speaking Canada or would like to see or hear the webinar, at least in closed captions, there is a link at the bottom in your control panel that you can click on for captions. It's under More when you just scroll your cursor over the bottom. And enough of me. Without further ado, I would like to give a warm welcome to Cindy Miller. Thank you.
Thank you, Chris, and thank you everyone that's joined us today. I am always glad to have time with Wounds Canada. I've just always enjoyed coming up there over the last 30 years of working with V.A.C therapy, and it's a pleasure and a joy to be with you today while we talk about this very new and exciting product. So let's get started. One of the things that I appreciate about anyone that comes to a webinar like this, or maybe you're going to listen to this on the Wounds Canada YouTube channel later, is that you're taking time to do what this slide talks about. It's a lot of small print, but what it really is saying is thank you for learning about products. Thank you for following guidelines and understanding what the contraindications and indications are. So thank you for your time today. We're called Solventum now. When I started, we were KCI. I love what's on the left, especially when I'm speaking to NSWACs or nurses or even mid-levels, because you do all those values every single day. You put patients first. We really do. We prioritize what's best for them. And by doing that, we help them get better or at least maintain their dignity. And that's winning with excellence. We solve what matters to that patient on that day. And doing that, hopefully we advance together. And I know every single person on this call lives with heart. So thank you again. Let's start getting into the content. Here's our objectives. First, I'm going to try to work through with you the design intent and how it works differently with wounds than what we were used to, try to use a big word, with traditional V.A.C therapy. We're going to review some outcomes. We're going to talk about how that helps your clinical workflow and the economic output. We're going to explore some of those considerations with this dressing compared to V.A.C Granufoam. Then we'll look at some of those insights by looking at cases. I really like to always show things that you can say, oh, I remember that, or I've had a patient like that. And then we'll definitely leave time for Q&A at the end. So as I said, Chris said, I joined here in 1992. And we didn't have V.A.C until 95. So I've been through all these innovations. I've been involved in that. And this is the product we're going to talk about today. It's the latest addition to our line of Granufoam dressings. It's just very, very different. I get a lot of questions like, well, it is a very different dressing. What types of wounds can I use this on? It follows the same Health Canada indications for wound types that you're used to. So you see all these different wounds that you're used to doing with Granufoam, but the wound characteristics will be a little bit different. That means our contraindications are the same, no eschar, no untreated osteo. All of the things you're used to with traditional Granufoam are still contraindications with this particular dressing as well. What I really like about what I've learned in the last 2 years about the use of V.A.C Peel in Place is that we have used V.A.C Peel in Place, we've used Granufoam for complex wounds. And it is still going to be necessary for us to maintain that expertise with that. But what Peel in Place does, because there's only so many hours in a day if you're in the acute care facilities. And if you're a community nurse, there's only so many patients you can see in a day. So I think over the years, we've sort of forced rank who gets VAC, understandably, and who doesn't. And so what this does is this is going to help expand the use of VAC therapy into more what we would traditionally call or think of as routine wound care. So it's going to complement normal granufoam. It's not going to replace traditional negative pressure. And so I want you to think of this as we walk through this today. We're going to build on what you already do well with traditional VAC therapy and those granufoam dressings, or even Veriflow Cleanse Choice if you've used installation therapy. They will remain the gold standard for those deeper, larger, more complex wounds. But with this dressing, we hope to see that it expands your ability to use those on smaller wounds, to use this therapy on smaller wounds. Because earlier intervention and a broader access, I think through this presentation and the cases I'm going to show, you're going to go, wow, well, okay, all right. And I think the reason that a lot of these clinical and economic things will occur is because it is so simple and yet it is so efficient. So one of my first objectives, if not the first, was talk to you about the design intent. Over many years, you've been asking us, I wish it was easier. I wish we didn't have to change it 3 times a week. Well, I get, the cutting and the keeping count, and what if somebody comes behind me and they don't look at the chart to see how many pieces are in the wound? So our scientists and engineers, in conjunction with many clinicians, came up with what we call an all-in-one integrated design. The name reflects that, peel and place. Now, I'm not as funny as I think I am, but I wanted to call it slap and dash, but they were like, no, Cindy, you can't call it that. But it is truly like putting a big Band-Aid on the wound. You open the appropriate size, you pull it out, and it's all integrated other than the SensoTrack tubing is separate. So let's start at the bottom here, and let's work our way up. So the bottom, what actually touches the patient's skin, only on the outside of the foam, is a silicone adhesive. And we know silicone, think of it sort of like a Post-it note. It's very gentle, it's very easy to apply, it's easy to remove, but it doesn't have a lot of great sticking power. So we'll get back to the rest of that. This is Dermatec Drape on with a little bit of advancement. Now, what touches the wound itself and the peri-wound skin is this perforated non-adherent layer. So think of this as maybe an adaptic touch incorporated into the dressing. So it really is very, very friendly to the wound. We don't have tissue ingrowth because of the way those perforations are spaced. Above that is a really thin piece of granufoam. It's 0.6 centimeters in height. So if you've ever tried to butterfly open a piece of granufoam, you'll know that to cut at 0.6 would be very challenging in person. Now, sandwiching all of that together is the top acrylic or acrylate adhesive layer. And when this touches the holes where the silicone drape is, that gives us that wonderful hybrid adhesive where it's very easy to apply, it's easy for the patient to remove, and you have up to 20 minutes after you first placed it to lift it up and reposition it in case you have a wrinkle. The hole is pre-cut. Believe it or not, looking at data over the years, this is one of the most common things that people make a mistake on, especially newer nurses or younger residents or physicians, is they don't cut the hole large enough to allow the technology that's in the SensoTrack dome to function with the algorithms in the machines. So that's the integrated kit. It comes in 3 different sizes. What I want to show you right now is the value. This is really sort of the secret sauce as to why it can be worn up to 7 days. Now, that is always your clinical decision. You are not being forced to leave it up to 7 days. A lot of people, as they're getting used to it, they'll put it on, say, on a Monday and then check it Thursday or Friday before they go into the weekend. That is absolutely your clinical call. So why did they make these and she's stretching it right here. And what you see when you zoom in is you see these itty bitty little openings. If it is laying flat on the table before you pick it up, you will not see them. You might see some little weird pattern, but you will not see anything opened. These fenestrations are almost like little pie crust slits. And only when they go down into the wound and they're stretched do they open up enough like you see here. This was on a wound model for 3 days at a recent conference I was at. And when I took it off to throw it away, I happened to just sort of casually turn it over and I went, oh my gosh, because I could see that they had been pulled open and they stayed open. So this is Really important because you don't want to ever stretch it on the intact skin because you're going to open those up and get those little, you know how that granufoam can give little bites to the skin. And B, this is why we don't have an exudate amount limitation. So it can just pull exudate up through those holes and put it in the canister. So it really does allow that removal of exudate, but you won't have a disruption of the tissue even at 7 days. And that's one of the reasons we're seeing patients have so much comfort on removal is nothing has, we do have some exuberant granulators and they'll granulate with traditional granufoam between the pores. So this won't happen. And so it also, now this is probably going to be one of the weirdest things if you've not had a chance to use it yet. We absolutely want you to lay this on intact peri-wound skin. Yes, indeed, the black part of the foam, which has that non-adherent layer, we want, and the design requires that this touch intact peri-wound skin and you don't have to pre-drape it. You're like, what? Well, let's walk through this and talk about it. So I mentioned that there's 3 sizes, and these sizes are going to determine which one you use based on the first thing is the depth of the wound. Because it'll hold it. We want it on the peri-wound skin so it can hold it in place. And then as the air is extracted, because it's a cover dressing, you put no foam in this. Please don't ever put any foam in the wound with this dressing, even if it's 6 centimeters deep. So the part that's on the peri-wound skin will hold that down. And as the air is extracted in that wound, the wound starts to lift up towards the dressing, and the dressing is moving down. It's sort of stretchy, and it moves down until the 2 touch. So if my wound is 2 centimeters or less, and it fits under this, I want to use the small. Let's say it's 3 centimeters. You would need to go up to the medium because you want that enough of it to stretch down into the wound. You don't want it to hammock across it and leave dead space underneath. And then for the deeper wounds or the larger wounds in length and width, you'll go up and use the large, which is up to 6 centimeters. And that's pretty incredible that we can do a cover dressing on a wound up to 6 centimeters in 2 minutes or less and leave it in place up to 7 days based on our choices. And I think one of the things we're seeing globally with this is that it allows consistent care from the hospital to the community. Sometimes here we have problems getting our home health agencies to get to the patient's home in time after discharge for that 3-day dressing change. This extended wear time gives a lot of flexibility, and in your province, you'll be able to figure out how that's going to help you take care of these patients. So I think one big thought is to think about Peel in Place as being something that expands and is not meant or intended to replace traditional granufoam use with VAC therapy. Now, what's really nice about this as well, because it uses the SensiTrack technology, every single therapy unit that you see on this screen is interchangeable. So the canister tubing will always interchange with the Peel in Place dressing and the granufoam dressings and the Veriflow Cleanse Choice dressings. You never have to take a dressing down just to use another therapy unit. And so that really does help enable those easier transitions. Additionally, we do know that some healthcare professionals prefer different levels of negative pressure. Some prefer negative 75, some 100, 125, 150. With these 2 particular units, which are durable VAC units, you have that ability to flex that. And we have tested this between 75 and 150, and that does allow enough pull, if you will, to open those fenestrations adequately. We have anecdotal reports, nothing proven or studied, that if there is a lot of exudate, if it is thicker, that it tends to remove the exudate better if you pump it up to 150, or if you're at 75 to increase it by 25. So once again, I mentioned it has same indicated wound types in Health Canada that you're used to. But now let's talk about some of the things we want to look for and some of the things we want to not try to ask this dressing to do. Because what I tell people all the time is, remember, the design intent was not for the complex wounds. It was not for wounds that you would really need the white foam or the granufoam. It was for the smaller, more moderate wounds. So any one of those wounds I just showed you that don't have any contraindications, I also now want to look at, does it have a tunnel? The way this works, as I mentioned, is it pulls up towards the drape and the foam while it's moving down into the wound. That does not allow this to go into a tunnel. So it might pinch the tunnel off here, which could leave a potential pocket or a nidus for infection, and we don't want that. So please don't put white foam in that. Please don't. use an alternate therapy, maybe potentially granufoam with white foam in that. If it doesn't have a tunnel, absolutely let's go forward and let's go to the next step in our decision tree. The next thing is, does this wound have undermining? Undermining is fine with this dressing up to 2 centimeters. If it's 3, 4, 5, it was not designed to be able to scoop that far into an undermined area. So please, if it's undermining greater than 2 centimeters, please use an alternate VAC therapy such as granufoam with white foam. Now, I mentioned there's 3 sizes, and I mentioned that it can be in wounds up to 6 centimeters deep. What's also interesting about that is that's one of the things. Okay, if it's 2 centimeters, or maybe it's a surface, a skin graft, or a donor site, because we have people here that are Y connecting. You know, the donor site's the most irritating wound almost a patient can have because it's just so raw and painful. So we have a lot of clinicians that are bolstering the skin graft like they do normally, much quicker in the OR, and then they're Y connecting it to the donor site because that ability to have it covered and left untouched for 7 days has been really appreciated by the patients. But let's move back to what I was talking about. I got distracted. Big surprise. So I want to look at medium, 4 centimeters or greater, or less, large, 6 centimeters or less. However, sometimes I'll have a wound that's fairly surface. Maybe it's 3 centimeters, but it's really long and wide. Then you want to step up to a larger dressing. And when I say that, you may have to go to a large when it's really only 1.5 centimeters deep because it's quite large. Maybe it's a big road rash or a traumatic injury. So this is what we want. We want you to size up until the point that when you hover that over the wound, you won't see the wound at all once you place that as the cover dressing. Now, why is that important? It's important because the design and the thinness of the foam and that stretchability of the Dermatac drape were meant to evacuate the air. And just like if you've ever seen somebody get the Chinese cupping, a lot of the athletes will get that after a race or something, and the outside edge of the cup holds it in place and then the soft tissue gets pulled up. This is sort of upside down. What we're doing is this is going to hold the skin in place, and as that air is extracted and the dressing starts to move down, I'll show you one video where you literally see at the very end of the drawdown, you see that dressing come up and actually, not the dressing, but the wound come up and be lifted away from where it was. If I use a dressing that is the right depth, but it doesn't cover all of the peri-wound margin, and I can see little bits of this wound sticking out, what will happen is instead of holding it here where I need it to be, it'll slide down into the wound. And then I'm not going to get that same lift and elevation. So please size up. And there's methods that you can, marry the 2 daisy chain them together if you want, if you have a long fasciotomy. So let's just talk about placement. One of the most pivotal things, besides what I just mentioned, 2, 4, 6, no tunnels, no undermining greater than 2, and cover the entire dressing, is when you apply it, please pull back the entire backing, hold it loosely in your hands. It's a drape. It's not that cling wrap that you stretch over a bowl of green beans before you put it in the fridge, and just lay it down over the wound, centering it as much as you can. And if you see this level of stretch on the drape before negative pressure is applied, it's your clinical decision, but you can reposition it for up to 20 minutes. You might want to consider lifting this section up because you'll see this thing retract back. You'll see it loosen up. And what that does is that gives you the highest chance of it going all the way down into the wound and dramatically reduces those fenestrations opening up on intact skin, and little bits of granufoam would touch it and cause that little red pattern that we see and sometimes it's very inadvertent. You don't know it till you take it down and then you're like, oh, I bet whoever put this on stretched it. So put that on, and then once you figure where you want the pre-cut hole, think about where do I want to route my tubing, and then once it activates, you can actually see it has taken on the shape of the wound. And that's one of the questions we get a lot is, how do I know if it's granufoam versus peel in place? Granufoam, we always fill up to the surface of the wound. This, we're going to allow it to pull the wound up to it. So in this video, you're going to see this pull down, and right here where you're going to see the shadow, at the very end of the video, I want you to watch and you'll actually see the tissue come up. I'll probably play it twice so you have a chance to see it.
Here we go.
Right there, that's where it just lifted. And I don't know if you could have heard, there were 3 nurses in the room, and the first one goes, here we go. And the next one goes, that's crazy, right at the very end. So let's watch again. Watch right here as this lifts up. Boom. It just lifted right up where that shadow is. It literally lifted the tissue up from where it was residing. So when we think about all the ease of use, extended wear time, it's not as hard to teach someone to do it. I'm never going to have to worry about retained foam because Cindy said don't ever put foam in it. Please don't. It's part of the instructions for use. It's part of the design intent. So now I'm not an expert on Canadian reimbursement, especially province by province. So I will lay this out before you and let you think through your particular practice, where you live, and what matters in your economic and clinical environment. So clinically, we're finding that it effectively helps it be used across a broader range of wounds. The patient comfort and experience will be just one of the things you love the most about it, and they do too. And that consistent therapy, because a lot of patients with traditional granufoam or even other dressings, non-negative pressure, if it's really painful upon removal, they just dread it. They really do. And I don't blame them. I hate pain myself. Now, operationally, let's think about trying to see a certain number of patients in a day, or your community in SWAC, and you've got X number of patients to see and drive to. The application reduction, the complexity reduction, and that simplified integrated design truly is 2 minutes or less for the most part, and that's a big switch. This whole thing, I'm going to take just a moment to explain what I mean by less procedural variation. If 3 of you were at a table with me and I gave you 3 identical wound models and I handed you, say, a medium granufoam, which is clearly too large for the wound model in front of you, I had you turn your backs to each other and take your time and place it like you would if you were a regular patient, if this was a regular patient. If I said, okay, when everyone's done, turn around, and I asked you to hold up how much foam you had left over, my guess is subjectively we put how much we think needs to be in there. I bet there'd be a variance between how much foam was left over. So what this does, by just laying it as a cover dressing, it allows the wound to decide how much it can move up, and it allows the dressing to move down, and we just have a real reduction in that variation in clinical application. And it really does allow you to treat these patients very efficiently. Now, those of you that are in acute care, and you'd like to send them out to the community or to another place that they will reside or stay, this up to 7-day wear time really gives some flexibility to when that first clinician sees them again after they're discharged, really helping not only your workflow in the acute care facility, but anyone in the community. It gives them that little bit of space to be there in a timely manner and stay within the guidelines. And what we're finding in the various countries that have had it for a while is it really does reduce the barriers to adoption and the ongoing management of the wound due to the extended wear time and no tissue ingrowth, et cetera, that I've mentioned. As I've worked with different healthcare professionals, doctors and nurses across the world, it's very interesting to hear these 2 words, different languages, of course, and maybe different ways, but boy, this is a game changer. I never knew. And I didn't either. I was really a non-believer when we first started launching, and I'm like, oh, no. I've been teaching this for the same way for 28 years. But it's okay if you're like, I don't know, how can this be true? I understand, because I had to be convinced myself by seeing it do what it is intended to do. So here's where we are finding people are starting to use peel in place, because complex wounds are still going to require granufoam and require your expertise. It's underutilized today, typically with the small to moderate wounds, because we have to reserve our time for VAC therapy for the bigger ones, because you can only see so many patients. Shallow wounds, we tend to think, no, they'll be fine. Because, granufoam granulates. Granufoam does not promote reepithelialization. Even though that's the end of proliferative healing, is that closure of the wound, then we go into remodeling. But you're going to find this is really beneficial for those. Lower exudate, we tend to think, no, I don't need VAC therapy. There's too little exudate. I'm going to show you some things that I hope will say, well. And we're finding it really help transition patients into the community. And what have we been doing? Of course, we're managing them often with advanced dressings or evaporative dressings, and this allows you that third choice. It is another tool in your toolbox that you can pull out, and as you become more comfortable with it, you'll be able to decide when you want to use it. So here's a question we get, because I just talked about we tend to not use it on the smaller, less exudative wounds. So let's talk about this gentleman. He's a butcher in Italy, still is a butcher, and he had ruptured his Achilles tendon 5 years prior to this photo. Now, it dehisced open, and he had lived with this open wound on the back of his heel for 5 years, working full-time on his feet all day long. So when the physician, Dr. Campiatello, got his hands on Peel and Place, he thought about this patient because he'd been seeing him for so long, and he brought him into the clinic. And of course, as you can imagine, with a chronic wound, with someone that works full-time on their feet 12 hours a day, there was a lot of that chronic maceration that we see. So thank goodness he, as he would, he debrided that all off and cleansed it and got it nice and clean. And then he said to the patient, I'm going to try something new. I'm going to put this dressing on you. I want you to thread the tubing up the back of your shoe, and we're going to bring you back in a week and see if it helps. And the patient agreed, so off he went. And so when he came back in 1 week. No, excuse me, this is third day. Sure, I'm confused. Day 3, that's even better. So once again, you don't have to leave this in place for 7 days. You don't. And because he knew there was going to be dependent issues, and he's under a sock and in a shoe and he's on his feet, he brought him back at day 3. So he placed it on the 4th. He changed it on the 7th. Yes, there was some wetness here, but please look at this wound that had been open for 5 days. So he probed it. It was actually closing. He let this dry out about 10 minutes. This will typically dry out like when you get out of the bathtub, you've been in too long. And you can see the exudate that was here. So let that dry out. He put another small peel in place, sent him back, and brought him back this time 4 days later. So he was on it a total of 7 days. So 5 years open, 3 days, 7 days. And when speaking to the rep who in Italy has this doctor as her customer, she said the patient has remained closed and said it has changed everything for him. So that quality of life and the patient reported outcomes that this can provide for wounds that, if you had called me 2 years ago and said, Cindy, should I put granufoam in that wound? I would say, why? But now we know that there's an option for you. So I've already mentioned this. How do we know if it's regular vac or it's peel in place? So regular vac, we count and cut, we fill it up to the surface, and even then it pulled away from the edges. We see that happen. And so that is traditional granufoam. This, of course, is peel in place. Because we have it on the intact skin, it's an oval. Please don't ever cut into the foam. Please don't ever put anything in the wound. And what it's going to do is going to hold the skin in place. It's going to pull the wound up away from where it's resting as it goes down. And that's when those little fenestrations stretch open, and you can see immediately the exudate that's starting to come out of that wound and be pulled into the canister, which is why you don't have to worry about only the low to moderate exudating wounds. You can use it for higher exudative as well. Cindy, okay, I've not tried it yet. What wound should I try it on first? Please don't go with the train wreck. Don't go first to the sacral wound that's a 0.5 centimeter from the anal sphincter. So let's start with something a little bit more moderate. And this one was one of the ones that would be very easy to do, but you don't have to wait for something like this to come along. Every wound would be appropriate for this dressing, as long as they don't have the contraindications that we mentioned, as long as they don't have a tunnel, no undermining greater than 2, and they're 6 or less in depth. That would make it an appropriate wound, but I'd ask yourself to give you a little grace and try something on the dorsum of the foot, or, maybe a fasciotomy or something first. So this was a patient that had that drainage of her left hip area, if you'll see. Here's a close-up of it. Nice length, nice width. If this had been only this wide and this deep, I would have said, please don't, because it's just going to hammock right across it, and it's not going to give time to pull the base of that wound up to meet the dressing. And you can sort of tell if you do that and it's pulled down, and you should feel the actual wound right under the dressing. It's thin enough that you can palpate that with your gloved hand. But if you feel it's springy, like it's a trampoline and it's suspended over air, there's a couple of choices that you can make. Did I stretch it? Do I pull that back and let it relax? Do I take that down and try a different size or a different type of dressing? So, but this is very, very ideal, easy to learn on. That was the day they placed it. And this is, now you're going to listen to some of the things they're going to say here. And if not, I think I've put the wording up there.
Oh, wow, that's just creepy.
Here we go.
What?
Just sucked right down.
Yeah, it sucked right down, so there's a little foam dent.
So there's 3 nurses in the room, and one goes, oh, wow, that's just creepy. And the the second one goes, there we go. And the third one, who must have been doing something different, is like, what? Because she missed it. And then one of the nurses said, oh, yeah, it just sucked right down. Oh, there's a little foam dent. And that's how you can really tell. And you're like, wow, did they need this much foam? Maybe, maybe not, but they adjusted what they felt was the right Maybe it was offloading the tubing out of the way. Maybe they felt that the depth of this was such that they wanted it to really go down and be able to touch the bottom. And this is the type of wound I would ask you with your gloved finger, just gently, whoops, oh, let's play it again, I guess. Just gently press that, see how it goes
Wow,
down
that's
into the
just
wound.
creepy.
And you really want to be able to feel the density of the wound tissue, not bouncy air if you do that. And you will see that dent. It's not going to hurt the peri-wound skin to have that much. They took it down at day 6. Honestly, if I had not seen this type of results so many times in the last 2 years, I would have said, no way, no way. And not every wound responds this way, of course, but we're seeing enough of them, especially the ones that are the early dehisced ones, the dehisced C-sections. We're seeing fantastic results with donor sites. But that was day 6, and this was the second removal, which was 12 days. So here was what they started with, and 12 days later. Now, I haven't really mentioned this so much yet, but as I did mention briefly, granufoam granulates. Peel in place has that slick undersurface that the epithelial cells, the little keratinocytes, they're like, oh, it's a nice, moist, I can swim across that versus getting pulled off with granufoam. So we are seeing a lot of edge advancement from the sides, especially once the surface gets a little bit flatter. Very common question. Does peel in place cause epibole? Well, let's look at this wound and you can tell me. If you think about the design intent and what it's doing by having it on the intact peri-wound skin and holding that in place on the intact skin and then causing that tissue to be lifted away while the dressing goes down, it's like a seesaw, right? We think about this type of subcutaneous tissue sort of movable, and they're very likely to get that epibole with traditional dressings. But I also want you to look at this not inflamed so much as it's just edematous peri-wound margin here. And you can see it definitely took on the shape. You can see where the exudate's starting to come out. And I'm going to do some close-ups to let you see in 5 days, this is no longer there. Let me close up for you. If you think of that peri-wound edge improvement, we're seeing this over and over again. You can see that drop off. You can see where that would want to be the type that would roll under and create epibole. But just like I'll say it so many times, you'll be tired of it. Holding the skin down, lifting the wound up, levels that out. And instead of this sort of cliff, because keratinocyte, epithelial edge migrate, epithelial cells will not jump off a cliff. They want to be able to slide in like they're going into those zero entry pools or at the ocean walking into the water. Is it really that fast, Cindy? Really? Come on. Well, let me show you a patient, and I've got a couple of videos. And this was a femoral incision dehiscence, as you can tell. And there's 2 centimeters of undermining from 6 o'clock to 11 o'clock. And you can sort of see by the shadow, that's sort of the hint that there's some undermining there. So this was a nurse that just graduated, just passed her boards, never had touched any negative pressure device or dressing. Marianne Obst handed her this dressing and said, okay, you're going to center this over the wound. I don't want you to pull or tug on it. And make sure you cut the drape if you think that it needs that before it goes down into the fold of his inner thigh. So she did. She cut off this corner. And we all know, never throw this away. You might need it until you're done. So she did that. Now, this video actually took 1:30 for her to place this, but I put it to 2.5x speed because I'd like to spend more time with you talking about other things. So she looks like one of those old Keystone Cop movies from when they were black or white. And so she just very gently just laid it down. All the backings are off. She just, a little stretch there, but not bad. And just laid this down and just push. You can always lift up those little wrinkles and unwrinkle them and then pop them back down on the skin. She puts the sensor trackpad. Here's the key for someone that's not used to this dressing. Turn on your unit if it's off, because by the time it fires up and is ready for you to hit start, you'll be done with the dressing. Otherwise, you're like, oh my gosh, why didn't I turn this on first? So that's when it pulled down and 1:30 in real time. Now, let's look at 5 days later when she takes this off. Same nurse came back. She was shadowing Marianne. Now, of course, we know, hold down the skin as you're pulling off any adhesive. So she's working around towards the wound, working your way circumferentially towards the wound, towards the wound. You will notice when she gets up to the pubic area, we won't see it here, but there's a little bit of hair she starts yanking on. The wound, it wasn't hurting the wound, but she had to like, okay, I'll hold down a little more carefully. And she removed that in 1 minute. And for this, it was a 20-second video because I sped it up for you. So that's how easy it is to apply and how easy it is to remove. So when they took it down at day 5, and I'll show you the original one here. We had this edematous tissue in the peri-wound skin. We had that 2 centimeters of undermining, and you can see here a lot of that has gone away. A lot of the ecchymosis is resolving, which it does eventually on its own anyway. But Marianne was so stunned with how much this had tacked down that she took a little cotton tip applicator and probed to make sure it wasn't like a little mucus curtain, making her just think that the undermining had tacked down, but it had. There's a close-up so you can appreciate that maybe a little bit more. So how do I offload that tubing? I don't want to have a device-related injury. You told me I can't cut into the foam. You told me all the things. Well, first, I always want to refer you to whatever pressure injury avoidance guidelines you use in your province, at your facility, or your institution's protocol. But I will show you a couple of options anecdotally that people have found are working. If it's the plantar surface of the foot, or if it's an ischial tuberosity wound, something that you can use the large and move that tubing out of the way, then you just put the tubing on the dorsum of the foot in this instance. What really surprised me when I was helping Marianne learn how to apply this product, and it's so simple to teach, but I was saying, we can't build bridges on this, because if you open up granufoam to make that, then you've shifted yourself back to 3 times a week based on the indication statement. She goes, "Oh, Cindy, I haven't done bridging in like 2 years." I'm like, "What do you mean?" And she said she has a large team. She's at a level 1 trauma center. And those nurses had a clinical variability in how wide they cut the foam, how tall they left it, how much did they overlap onto the granufoam in the wound, et cetera, et cetera. And she was finding that there were some problems because it would pull apart or be too thin. So she looked up the NPIP guidelines, and what she decided was to use the protocol that they recommend for padding IV tubing, Foley's, anything where there's like a LVAD or something that's going on. And so what she did was she took the 5-layer foam that they use there. They use the Monlica, which is a great foam, and she cuts a slit. Then she slides it up and sort of cinches it around the Sensitrack pad, and then she secures that with some sort of clear transparent film. And she showed me this picture, and I'm like, "So how many pressure injuries have you had with this technique?" She goes, "Not one." She goes, "We have to track that, of course, because it's reportable." And I'm like, "Huh." She goes, "It's just so fast. It's so easy. It's cheaper than opening up another granufoam kit." I'm like, "Oh, good for you." So I'll share that with you. That's her experience. So, all right, now what happens to the patient? What's it like when they really take it down? You say it really doesn't hurt. Let me show you this, because that's what they're saying to us a lot. People that had a 10 out of 10 pain anecdotally are reporting a 0, 1, or maybe a 2. It's just really been fulfilling as a nurse to see these patients have a much better experience upon dressing removal and application. So this is Dawn. Dawn was 70 years old, pancreatic cancer, had surgery, and unfortunately the wound hissed open. They were using traditional granufoam inside this wound, and I'm sure you all know exactly what that is. Whoever did that application, this is that variability in application, had the granufoam inadvertently touch the intact skin, and that causes that temporary skin damage. But that's one of the things about traditional granufoam. It's got some nuances that are, you have to do a lot of training. So both ends of the backing off, you see she's just literally laying it down like you would drape a tablecloth. She's just laying it down. She's not tugging on it. This took 30 seconds to go from here to here, which is why you want to turn on the therapy unit before you start the dressing application. So this is Don telling Marianne about his experience.
How was your VAC placement today?
The VAC placement compared to the earlier one where the poor nurse patiently had to strip away layers, put on gallons of, what is the solution?
Lidocaine.
Lidocaine. I thought they were going to flood the floor. This is wonderful.
Thank you so much, Don.
I don't know about you, but since I've been working with this since 95, I've had very few patients tell me that this was wonderful. So that was when they reapplied for the first time the peel in place. Here's where they took it off for the first removal at day 5.
This will be so good for home nurses when they go to change dressing.
Oh, Don, I just love that you're so concerned about other people.
Well, I'm a pretty boring person, you know.
That's not true.
You all have dead bad looks when you come in, like you're looking at death itself.
All right, here's the sponge part. Look at that.
Oh my God, it's filled in.
Oh my
That's
goodness.
insane. Wow.
Oh, I worried about this all.
Last word got cut off. Oh, I worried about this all week. They started it on a Monday, and Marianne and the team wanted to look at it on Friday before they left for the weekend. And so, one of the things I bet you noticed is that he's talking through the vast majority of that dressing removal. And in my experience, and yours may be different, patient pain causes them to get quiet. They grin, not grin, they grunt, they clench, they might moan, and he was just yakety yak. So I just love our patients and their experience with this. So that was when they started. Here's that first dressing change you saw at day 5, and in 2 dressing applications it was up to surface. And one of the things Marianne told me when I saw her at WOCN, which is our version of Wounds Canada, she's like, Cindy, my surgeons are freaking out over how fast these dehisced wounds close with peel in place. And so they feel comfortable using it earlier, making sure there's not a deep infection or hematoma or seroma. Because if you think about it, a surgeon cuts into a wound, into intact skin, retracts it open, fixes the problem, then closes it in layers. And if that wound dehisces open, it's not like a shark bite where a chunk of tissue's been taken out. It's just opened back up. It's unzipped. So by not putting anything in the wound, by letting the wound contract as much as it can, because it was closed just days ago with sutures, it allows a very intriguing and fascinating body response. It's just been very fun to watch this and how patients respond. All right, Cindy, you told me I can't bridge away from the pressure injury, from the bony protuberance. What about 2 wounds? What if I have 2 wounds? Well, if they can fit under one foam and they meet the criteria, one's not infected and the other's clean, you can do that. This is a patient on Carrot Couches, and she started this last year on May 23rd. Ostomy takedown. She'd had clearly a dehiscence. They were vacuuming this, bridging it together, a little bit of foam here, deeper here, and it just took probably 30 minutes at least for her team to be able to do this. So she took the large, she angled it sideways, and she was able to grab almost all of the incision. This was just basically right here at the top where it was almost closed, and cover the ostomy takedown. And she said the patient was like, oh, that was wonderful. Here's where I was like, when she took it down, the ostomy takedown was closed, and she didn't get a picture. She just put a hydrocolloid over it. I was like, Sarah, where's she goes, oh, Cindy was closed. So now she just had a little bit more here that she wanted. So she took the medium and just put it vertically and left it on for, I think, 7 days more. And at the second removal, this is what was left. So really, really very good response for that patient. And yes, you can bridge wounds together. All right, I've heard it causes maceration. Why? Well, I think any wound that we've treated that the exudate is overwhelming whatever dressing you're using can be a problem. This was a patient from Italy, and he'd had this wound, mixed arterial venous, for 3 years. This was a fairly new wound, which had just ruled by nothing else could be diagnosed. They just started calling this PG, or pyoderma gangrenosum, and we're finding tremendous response with that type of wound because it just doesn't hurt the wound, it doesn't re-inflame it. Clearly, you're going to do your systemic stuff. The day they placed it was here. And this is a close-up. So this skin is unhealthy. And you'll see when our lower extremity wounds or diabetic ulcers with that hyperkeratotic skin, if exudate touches any of that really dehydrated, very dry, flaky skin that's biologically unhealthy, it will fluff back up. And the thing about when you look at this next picture, that's alarmingly white. That's like lightning bolt white. That has definitely got some maceration going on there. It's also got some hyperhydration or overwetting of the skin. But true maceration is a concern if and when it causes the wound to get bigger or other things to happen. When we look at this wound that had been open for 3 years, and this PG case wound that had been open for 3 months, and we see what 1 week did. Let's go look at this close up. 3 years open, 1 week. 3 months open, 1 week. So can we deal, if the wound looks good, and this secondary concern of maceration has not made this be worse, not just look alarming, that's your call. It's always your call when you start and when you stop different therapies. But I would just encourage you to first, if this is alarming, you're going to want to look at that first, evaluate how the wound responded. And we see a lot of depth reduction here in both of these. So that's certainly something that you can think about. Now, last but not least, practically, why do I see this sort of weird film on some of these wounds, and why is the tissue less beefy red than what I see with granufoam? So here's a patient, one of our first patients that we did down in Chile, and chronic diabetic foot wound, as you can see on the dorsum, extended up here. They folded it like a taco and tucked it down. This is how they opted to do it. Other ways to get a seal, but that's how they chose to do it. So that was the day they started it. Look what happened at day 4. You're like, oh my gosh, what happened here? Well, what happened here was the proteins that were in the exudate didn't have as many pathways out because it wasn't granufoam. And so they laid on the surface of the wound. It was not smelly. It was not firmly adherent like slough would be. It wipes right off. So we're calling this proteinaceous debris, and it typically only happens the first dressing change or 2. So day 4, by day 7, and we're hypothesizing, lots of studying to do, that as it's lifting that tissue up from where it's resting, it allows those tiny little lymphatic capillaries to be reactivated. And they're like, oh gosh, good, because I don't operate well under pressure. And so that's what we're thinking is happening. So now the proteins and that edema that we're seeing in that periwound area resolve theoretically are being managed by the lymphatics. Look at this at day 11. Here's day 14. 14 to 18, this is when they stopped the therapy and put them on advanced dressings. So that's and you could have stopped it at day 4. That would have been your choice. But now that you've attended this webinar, and if it wipes off and it doesn't have that purulent, gross smell, you might opt to give it one more try. Good cleansing, good wound hygiene, but from here to here in 18 days is pretty remarkable. So I'm closing down, getting ready to open up for Q&A, but I wanted to remind you that the complex wounds will always need your expertise, and they'll always use traditional granufoam or Veriflow Cleanse Choice. Those moderate wounds, or those wounds that you're treating with evaporative dressings or advanced wound care, rethink that. This is something that you have an opportunity to potentially expedite their ability to return to their activities of daily living. Our working adults, this is really a fantastic win for them because the patient-reported outcomes are so positive. And I haven't mentioned this yet, but you do not that non-adherence built in. Skin grafts, lay it right down over it. Donor sites, lay it right down over it. Tendons and bone, lay it right down over it. Now, if I see pulsatile arteries, you want to rethink that one, and you want some multi-layers first, and then you can lay that down on top of it if you choose to do so. So whether it's pretty shallow, moderately deep, or up to 6 centimeters, you can use VAC Peel in Place, and you never, ever, ever have to, much less I beg you, please don't put any foam or filler in the wound, but you never have to put that in the wound. So we've got that faster application, which gives you these benefits, that extended wear time, which really helps that transition. And it's not impacted by how humid it is. I live in San Antonio, Texas. It is humid here. So the evaporation rate is always dependent on humidity, or it's part of what it's dependent on. So here you have that consistent, predictable performance, and it really does let you manage more patients kindly and without impacting your workflow efficiency, and very consistent transition. So we feel that we're redefining the standard of VAC therapy for those moderate to smaller wounds. And all of these things I've talked about, I'm going to skip over to questions. I'll show this at the end, but here's what we hopefully covered. Design intent, how it works, the clinical outcomes and workflow impact, which will be determined by where you work and what type of setting. That will provide some economic considerations, and hopefully you've learned and you can apply some of these insights. So Chris, let's go ahead and open it up for Q&A.
That was amazing. You are a wealth of information. Thank you very much. That was a great presentation. The chat is filling up. I just wanted to remind everybody, please, the Q&A is open right now. Please go ahead and continue to add to that as you feel free. And at the end, if we don't get to everything, we will take away and we will answer all of these questions on the backside. Really, one quick one, probably more directed to me. Prior to working this suggestion into our practice, is it possible to get samples, test/use for demonstration or staff training purposes first? Yes, absolutely. At Solventum, we pride ourselves on the education front. Please reach out to myself or any of our account leads in the field under the wound care group. We would be happy to assist you, whether it's education samples. Of course, you want to see it, touch it, feel it, and we believe the proof will be in the pudding around that one. Here is one great question. Cindy, what about a wound on the foot in between the toes. It's hard to get a good seal when the foot is one of the hardest body parts to dress. Are there any suggestions on how to get a good seal?
I think that there are many ways to walk through that. One would be your famous little paste strips, or whether you have your paste or your rings, and you know how you can. In fact, if you take one of the strips or the one of the Eakins types of rings and open them up, and then you make your snake. One thing I've learned from another clinician just about a month ago is if you take that and twist it like that pasta you buy, it gives it more surface area. Then you can tuck it up on the plantar surface behind the toes, or you can wrap it around the front. And that extra surface area, when you use the Dermatec drape and you sort of pinch it around, it will stick very well. So use all those things that you would use typically on the sacrum or the ischial tuberosity. There are ways that you can cut that, and your local rep or your local clinical specialist would be more than happy to show you some of the tips and techniques. I'll see if I can gather some other stuff up and make sure, because I get to see things from all over the world, but it would be just like you do. But sometimes if it's just too much and you've used all those tips and techniques, you just got to step away and say, that one's not going to work.
Fantastic. That's great. Here's another question. Hello, thanks for the presentation. Just to confirm, so we don't apply tape on the edges prior to this.
That is such a good question. Now, I will never tell you you cannot do a thing, because you are the clinician and you get to make the clinical choices. But the design intent, as long as you don't stretch it, is that it can be laid right down on that intact skin. This is fantastic if you have someone and they're on bed rest and they've got one of those weird, looks like the Hawaiian Islands of a venous leg ulcer, and you can just lay that. You don't have to picture frame. Plop it right, plop's the wrong term, lay it gently down over all those oddly shaped wounds, and then you'll be able to, it's such a time saver. Now, let's say that you take it down and someone inadvertently stretched it. Then you might want to think, okay, do I need to protect the skin now? I didn't, but maybe it got stretched. So that would be your call, whether that's a transparent film or whether that's a thin hydrocolloid. Maybe you want to use some Cavalon Advance. But the vast majority of the users, and especially my high-end users that have done this a lot, they don't. They just don't. They had the same questions. I do not blame you for any and all questions that come through. But as long as you don't stretch it, if it's already denuded, then that Cavalon Advance would help. Good question.
Excellent. Excellent. Can I use it to treat scrotum abscess, opened and irrigated and debrided to 3 centimeters by 4 centimeters, 2 centimeters deep?
I'm smiling because I wish I'd put a couple of those in there. We have a nurse practitioner at George Washington University Hospital. It's a level 1 trauma center in downtown DC. And she has a urologist who specializes in a lot of this reconstruction. They have done at least 5 of those. I'm begging them to open up, and do a poster on that, or minimally a paper. But of course, you got the patient frog leg. You want to dry everything as much as you can. And then what you'll do is you'll sort of almost fold it up like a taco and center that over the wound. And then hopefully you have a friend holding some of the folds out of the way, and then just walk that drape up in there. But we have numerous positive outcomes with that. She even showed me one the other day where it was Fournier's gangrene, and they had to deskin the penile shaft, and they were able to wrap that up around that and extend that down. Yes, it takes a little bit of thinking, but we can certainly do that. Yes.
Excellent. There are so many great questions. How about a perianal fistula after fixed surgery? The incision dehiscence is larger, 5 centimeters by 3 centimeters, 5 centimeters deep. Is it okay for peel in place? What do we need to be careful not to cause a new fistula?
Say that to me again, the first part of it.
A perianal fistula after fixed surgery. The incision has a dehiscence that's quite large, 5 centimeters by 3 centimeters and 5 centimeters deep.
Okay.
Is it okay for peel in place?
So if I'm understanding the question correctly, they had an anal fistula, they fixed it,
Yes.
and now where they did that incision and fixed it has opened back up. So
You got it.
first, you'd want to be sure that it has not opened the fistula back up as well. So you'd want to be sure that you understand what you're facing. So if there's foul smelling, exudate, fecal type of smell, you would not want to do this. But if the surgeon and you feel that this is still closed, but I'm at risk, this is actually safer than using granufoam, because even if you had laid Adaptic down or Adaptic Touch down over where that had been, when you put granufoam in there and that pulls together, that can shift and then the granufoam can touch the tissue. So I can't guarantee the outcome, but could you do it as long as you felt comfortable that the anal fistula was still closed? Yes, potentially, but I wouldn't leave that one in place for 7 days. I'd look at the exudate. I'd see if the patient had started, if their white count was going up, if they started a fever, if they're in the hospital. But I would probably change that at day 3 or 2.
Wonderful. Okay. How is this technology different from other technologies currently in the marketplace?
Wow, many ways. Well, I've showed you how it's different from our granufoam, and every other regular foam-based negative pressure would apply. I think it's different from an absorptive dressing like an alginate or a super absorber, because if you use an alginate or super absorber, which we do, I mean, we do, it's still going to be part of what we do, that fluid is kept against and inside of the wound, whereas with this, it pulls it away. If you're talking about a disposable evaporative dressing that applies negative pressure, I have not seen enough comparisons yet to give you anything more than opinion. This is great for those higher exudative wounds. It can go up to 6 centimeters deep. We plead with you to not put any foam in that. So that would be some of the differences that come off the top of my head.
Can you use a contact layer like Inidine first?
Well, here's what I beg. I beg a lot of people, especially my surgeons, please don't go maverick on me right away. Use it according to the instructions for use. If you do decide to go outside of that, then please write and chart why you're doing that. I would prefer you not. I would query myself. I love Inidine. It's a fantastic dressing. I love how it changes colors. Why am I doing that? If it's still, I'm so worried about bioburden, maybe I don't do this yet. Maybe I want to do some real good wound hygiene. Don't put it on at first, in my advice, because I work for the corporation and I'm going to stay on label. And then if when you take it down at day 2 or 3, you are dissatisfied, I can't tell you what to do because then I would be talking off label. But for instance, here in the United States, we have Promogram Prisma, FDA indicated to be used under peel in place, but they're very specific that you have to cut slits in it because they don't want the exudate trapped under that peel in place. Excuse me, the Promogram Prisma. So I'll have to stop there because I like to stay employed. I can't tell you what to do off label. Good
Absolutely.
question.
Here are 2 maceration questions. Sort of, I'm going to do a twofer and mix them together here. If there's macerations, could you paint the peri skin with Benadine and then cover it with the peel in place? And here's another one on the maceration area. Can hydrocolloid barrier sheet be placed first to protect that area before reapplying? So 2 sort of aspects they're looking at that.
First question, let's address the betadine. There has been no testing that I know of as to how, first, anything you put on the skin, you want to let it cure. You want to let it dry, whether it's No Sting or Cavalon Advance or betadine, which we have no testing, so I can't give you any advice or guidance on that. But there are other things you can use that we've tested, like the Cavalon Advance or the No Sting. If you do that with the betadine, I don't know what would happen. Clinically, that will always be the clinician's call and not ours, but we have no testing to tell you yay or nay. The next question was, I think about, is it already wet and moist? Is that right, Chris?
Yeah.
So there's a lot of variety of what people do where I've seen it used for an extended period of time. Some will put a little bit of prep, whatever you have of skin prep on that, and let that dry, and then put that ultra, the thin hydrocolloid. Or if it's really wet, they'll use a thicker one. Just have to extend the drape beyond the edge of that because that foam. But if it is wet or denuded, in my opinion, Marianne Opes calls this her secret sauce is Kevlon Advance. You click that little thing, you just do that single swipe, and that will stay good, even if it's exposed to incontinence for 7 days. So under the drape, as long as you let it cure that 60 seconds. And 60 seconds will feel like 5 minutes, but you have to let anything you put on the peri-wound skin dry. Good
Well,
question.
thank you. Unfortunately, we are running low on time. I know I could keep going with questions all night. I know. It's great. We will
I'm
get back to everybody and answer all of these questions. I
I'm
just
so
wanted to say,
thankful for everyone that joined us today, and it'll be on the
yeah,
Wounds Canada YouTube site. And I really hope you encourage your friends to go there. If you want to ever have me call in on a watch party with your province, we can do anyone or your local people can help you with that. But I am so appreciative for all of you for joining us today. Thank you so much. And thank you, Wounds Canada, for hosting this.
and
Chris?
a big thank you to Cindy for such an engaging talk. I know that it is probably the last day of school for those with children, and it's a busy time. So wanted to thank everybody for joining us today. I hope you've been all enjoyed the Solventum V.A.C Peel in Place dressing, enhanced outcomes and efficiency in acute and community care. Please don't forget to take the survey to receive your personalized certificate of attendance. A follow-up email will be sent next week for the opportunity to view the on-demand presentation as well. And again, we will send the link for the survey if you're unable to complete it today. If you have any other questions, please reach out to me. My email is posted in the chat, cjquinn@solventum.com. It's Chris Quinn, CJQUINN at solventum.com, or info@Wounds Canada. And finally, on behalf of myself, Cindy Miller, Solventum Canada, Wounds Canada, a big thank you for everybody for taking time out of your very busy days. We're very grateful for you, and thank you for joining us this evening, and have a great night. Thank you.